Thank you so much for the opportunity to talk to you today about new era in the management of thyroid eye disease. My name is Alzahrani. I'm from King Faisal Specialist Hospital and Research Center in Riyadh. This is my disclosure. I'm a member of the advisory board in the Gulf region for Amgen on thyroid eye disease. So, thyroid eye disease is considered an orphan disease, and it's an orphan disease because it's not very common. The incidence rate in men is around 3 cases per 100,000. It's much more common. It's around 3 times as common in women, 16 cases per 100,000. And it has two peak age in women and men. In men, it tends to occur 5 years later than women. So one peak is at 45 years to 49 years. And then another peak at 65 to 69 years. Women, 40 years to 44 years, and then 60 to 64 years. Now, although thyroid eye disease and Graves' disease are very much linked, but they are not synonymous, and thyroid eye disease may coexist, precede, or follow a Graves' disease. And thyroid eye disease, as we know, may occur without hyperthyroidism. And in fact, it may occur even with hypothyroidism. However, hyperthyroidism affects the course of the disease. And patients who have hyperthyroidism are less likely to improve with treatment. So maintaining euthyroidism or achieving euthyroidism in Graves' disease is important in the management of this disease. Now, there are multiple risk factors. Some of them are non-modifiable, like age, advancing age, as we have just mentioned, is associated with the increased risk of Graves' eye disease or thyroid eye disease. Women tend to be affected more, as we just mentioned. However, men are more likely to have severe disease. And obviously, genetics are important in any immune-mediated disease. There are important modifiable risk factors that can be changed. One of them, and very important one, is smoking and radioactive iodine therapy in patients with moderate to severe disease. Those two factors are modifiable and need to be controlled. Thyroid dysfunction, as we just mentioned, although not directly related to thyroid eye disease, but they are very important to be corrected to be able to manage the disease more effectively. Now, thyroid eye disease has, in general, two phases. Sorry for this. One is an acute phase, and this is a golden opportunity to interfere and try to change the course of the disease and prevent complications. And this is usually within the first 9 months of treatment. So this is an ideal time. This is the acute phase. This is an ideal time for intervention. And then the disease usually goes into chronic burnt out disease long term. What became clear over the last few years that there is still an opportunity to interfere and change the course of the disease and improve the patient's quality of life. Although the therapeutic window gets narrower as we proceed, but there is always a chance to make a change, especially with new treatment like teprotumumab. Thyroid eye disease affects essentially all elements of the eyes or all components of the eyes. So it affects the conjunctiva and cornea, and patients may present with chemosis, conjunctival redness, tearing, photophobia, and foreign body sensation. For the eyelids, they can have eyelid swelling, pain, lack of thalamus, and that may lead to exposure keratopathy. Orbital fat, it increases significantly, and that causes pain, disfigurement, proptosis, exposure keratopathy, and may lead finally to visual loss. Extraocular muscles are affected, and that leads to restriction of ocular motility. Diplopia happens in around 50% of patients, and that's very bothersome symptoms. You can see here an image of how patients with thyroid eye disease with significant proptosis and diplopia see images primary image that is not very clear, and another image that is totally unclear, but quite disturbing for the patient. And optic nerve can be involved in severe eye disease, and that's a very serious complication that may lead to complete blindness with loss of vision, impairment of color vision, and entrapment and swelling of the optic disc, and finally loss of vision. To these, you can see that the thyroid eye disease involves essentially all structures of the orbit. Now, thyroid eye disease is not simply an eye disease. Although the eye is very important, it is a systematic disease, and it has major burden on the quality of life. Patients have problem with their vision. They cannot see well, and they see everything abnormal. They have problem with the way they look, as you can see here. And all of this affects their quality of life and their psychological well-being. So in a study of 41 patients with thyroid eye disease, 75.6% of them had altered visual function, and 95% of them had disturbance of their appearance. They have perceived their appearance to be completely abnormal, and that leads frequently to depression and anxiety, unhappiness, and poor quality of life. We just mentioned that thyroid eye disease affects all elements of the eyes, and this is clear in this diagram. A healthy eye is well protected by the eyelid. The optic nerve passes through the apex easily and freely, and the orbit contains a small amount of tissue and fat, and therefore everything functioning beautifully and in coordination. In the presence of moderate to severe thyroid eye disease, all of these elements are disturbed. So you have lid retraction, eye protrusion, lid and conjunctival redness, and that leads to inflammation and enlargement of the muscles, and of course, diplopia and distorted eye orientation, compression of the optic nerve at the apex that may lead to actually severe compromise of the nerve and visual loss and even blindness, and increased orbital tissue, fat, pressure, and protrusion of the eye. Now, thyroid eye disease is well known to be immune-mediated disease. However, the trigger for the autoimmunity is not known. What is known is that we have lots of immune output, immune reaction output. Autoantibodies are very rich in the orbit, leading to activation of the fibroblast, inflammation, tissue expansion, remodeling, and distortion of the whole eyes. And the two autoantibodies that are very important is one against the IGF-1 receptor, which is overexpressed in thyroid eye disease, orbital fibroblast, and also on beta and T cells, and also the TSH receptor. Those antibodies, autoantibodies, activate the IGF-1 receptor and the TSH receptor signaling complex. So both of them combine together in a complex and get activated. They activate the orbital fibroblast, which leads to release of inflammatory cytokines and material, and hyaluronan material that leads basically to expansion of the orbit and pressure in the posterior aspect of the orbit, with distortion of the eyes, protrusion of the eyes, and malalignment of the two eyes. Once activated, orbital fibroblast causes inflammation and expansion of the tissue, muscle, fat cells behind the eyes. This cartoon illustrates all of this. So basically, you have a lot of autoantibody against the TSH receptor and IGF-1 receptor. Those antibodies, when they bind to the IGF-1 and the TSH, stimulate the fibroblast. Fibroblast becomes very activated. Some of those fibroblasts becomes myofibroblast, and some of them are differentiated to adipose tissue. Obviously, this leads to orbital fat expansion and increased volume of the orbital tissue, At the same time, there are lots of secretion of aminoglycans, and inflammatory molecules, cytokines that leads to activation and chemo attraction of the beta cells and T cells. So the end result of all of this is severe inflammation, increased volume of the orbit, and expansion of the orbit, and all the consequences of this. This is just another way to look at this. I just want to emphasize the role of IGF-1 receptor in combination with the TSH receptor. When they get stimulated, they form a complex, and that stimulated the fibroblast, and the fibroblast is at the center of all of these consequences: reaction, inflammation, expansion, and so forth. Now, let's move to the management of thyroid eye disease. And let me start with a bottom line, because this paper, or this consensus statement that came as a combined effort of the American Thyroid Association and the European Thyroid Association, released late in 2022, is becoming more or less the roadmap and the textbook of treatment of moderate to severe eye disease. So what does it say? Basically, this table summarizes it all. It depends on your treatment goal. So if your treatment goal is to inactivate the disease and reduce soft tissue involvement, then they still think that the intravenous glucocorticoid is the preferred therapy. But you can see that teprotumumab or radiotherapy plus IV glucocorticoid or oral glucocorticoid are acceptable therapies. And there are some other options that are called here considerable therapies or acceptable therapies or second or third line therapies, actually. So that depends on your aim. If you have diplopia or proptosis, this is a clear indication to use teprotumumab. It is the first line of treatment, and I believe that most patients with moderate to severe thyroid eye disease would have a degree of diplopia and proptosis, and this drug has been tested very well in these situations and shown to be very effective. Therefore, they choose this as the first line of therapy. If the issue is mainly diplopia, a second line therapy is radiotherapy, an IV glucocorticoid or oral glucocorticoid. I must say that radiotherapy is not popular for its possible effects and for also the fact that it's not easy to do. You need several days or even a few weeks to complete that course. So this is becoming basically the first line therapy, teprotumumab, in situation when you have diplopia or proptosis. When you have eye motility disorder and you need to improve it, IV glucocorticoid, radiotherapy, and IV glucocorticoid or oral glucocorticoid, and teprotumumab are all options. So again, I think what you can see here that teprotumumab has a place in all of these objectives or goals as either the first line of therapy or the second line of therapy. And I think what is also another message from this table, that if the patient has diplopia or proptosis, then your drug of choice will be teprotumumab. And I think this will even change over time in this direction. Now, what is teprotumumab? It's it is actually antibodies against the IGF-1 receptor. Basically, that the mechanism is as follows. So you see on the left side here the mechanism of Graves' ophthalmopathy or thyroid eye disease. We mentioned this before. IGF-1 receptor autoantibody or TSH receptor autoantibody combine with their receptors and induce a complex of that leads to activation of fibroblast with all the consequences that we mentioned. What we need is to break this cycle. So you would need a drug that interfere with the combination of IGF-1 receptor with its receptor, with IGF-1 autoantibody with its receptor, or a drug that interfere with TSH autoantibody, TSH receptor antibody with its receptor. There is no drug for this one so far, but we have a drug for this one, and that's teprotumumab. What it does, it occupies the receptor on the fibroblast. So it breaks the cycle. It prevents basically the O2 antibody, the IGF-1 receptor antibody, from combining to its receptor, breaking this cycle, leading to basically inhibition of the fibroblast from going forward with the effects that we mentioned earlier. Teprotumumab has a very extensive clinical trial database. This started with phase 2 trial, which started in 2013. It is 24-week trial with 48-week follow-up. This was published as a first study in 2017 New England Journal of Medicine, and was phase 2 that led to subsequent phase 3 trial, which was also published in New England Journal of Medicine in 2020. It has the same design. We'll describe those trials in details. Then phase 3 was extended for another 48 weeks, and it's called sometimes Optic X. So it's extended. This is Optic X. And then we have recently phase 4 trial, which treated patients with chronic disease, with chronic thyroid eye disease. Those two trials here, phase 1, phase 2, phase 3, and phase 3 extended, were for patients who were treated with acute thyroid eye disease in the acute phase within 9 months. But this one was for patients who had disease for 2 to 10 years, and they were in chronic phase. Now, as you know, the Japanese, they do their own trials, and there is a phase 3 trial Japanese, and there's also chronic Japanese trial phase 3. And there is post-marketing phase 4 recording of safety and efficacy that is common for all drugs. So let's discuss phase 2 and phase 3, the Optic trial, these two phases, this one and this one, because these were the fundamental trials that led to FDA and FDA approval of the drug. So in phase 2, 112 patients were eligible for recruitment. 24 were found after screening to be ineligible. So 88 were randomized to placebo or teprotumumab, 45 versus 43. In Optic trial, the same thing, 107 were eligible. After screening, 24 were ineligible. So a total of 83 were randomized to placebo or teprotumumab. Now, looking at the bold data, so we have a total of 87 placebo, 45 from phase 2, and 42 from phase 3. And then we have 84 teprotumumab, 41 from phase 3, and 43 from phase 2. And during the trial, 8 patients on the placebo discontinued for various reasons, and similar number, 8 patients withdraw or discontinue for various reasons. You can see adverse effects or withdrawal. And then 76 completed the studies on Tepro and 79 on placebo. So let's look at the results. This is phase 2 that was published in 2017 in New England Journal of Medicine and was the first trial. And then this is phase 3 that was also published in 2020 in New England Journal of Medicine. This is phase 3. So let's look at the combined results of this. First, the design of those trials. So all of them had the same design. Patients who were included are adults between 18 to 80 with acute phase thyroid eye disease less than 9 months, with a CAS score, that's clinical activity score, more than 4. Their thyroid function was within 50% above or below normal. They excluded pregnant women and patients who have severe or serious visual deterioration with possibility of optic nerve compression. And they also excluded any patients with prior therapy or surgery. So those patients were naive patients to therapy. They were screened, randomized to active treatment, teprotumumab, which was in the form of infusion every 3 weeks, a total of 8. So that's basically 24 weeks. And then placebo, the same thing, infusion every 3 weeks, a total of 8 infusions. This is 24 treatment phase. And then the primary endpoint was assessed here, which was basically a reduction in proptosis by 2 or more milliliter at 24 weeks. And then there was a follow-up period for 2 years, for 48 weeks, additional 48 weeks. So we look at the results. So this is basically the comparison of the different patients in phase 2, phase 3. They are more or less comparable. So you have the ages was around 50 for all patients. Females were the predominant, consistent with the incidence of the disease in female. White, mostly Caucasians, but included some Black, Asian, and others. Time since the diagnosis of Graves' disease was 0.9 years, so roughly 9 months. And time since the diagnosis of thyroid eye disease was only around 5 months in all of them. Around 25 to 40% were smokers, so they are very comparable in the two arms, whether in phase 2 or phase 3. They assist the activity by the clinical activity score that is composed of around 7 points. I don't have time to go over them. And then during the follow-up, there's 3 additional points, so 10 points in the follow-up. And activity score more than 3 initially in the initial visit, or more than 4 in the follow-up implies an active inflammatory stage of thyroid eye disease. They assess the severity of the disease by the European group of Graves' arthropathy, which is a standard mild disease, moderate to severe disease, or sight-threatening disease. And again, there are criteria that I may not have time to go over their details. But as the designation here indicates, this is a mild disease. This is a moderate to severe disease that is associated with significant effects on the patient. And this is a very serious sight-threatening condition that needs immediate intervention. What were the main results? As you can see here, proptosis was the primary endpoint, and patients who were on teprotumumab achieved the primary endpoint of 2 millimeter or less. 83% of them achieved this target, while in the placebo, only 9.5. So there's a difference of around 74%. This is a clear, it started actually early in the treatment after 6 weeks, and then continued to be maintained and increasing throughout the course of the trial, 24-week trial. You can see if you put proptosis and clinical activity score, you can see similar pattern. Patients start to achieve this early in the course, maintained it, and increasing actually the difference between the active treatment and the placebo. So at 24 weeks, 70.8% difference, 78% of patients achieved the target here, and only 7% in the placebo. So this is very clear difference between the two, starting early and consistently increasing and maintained throughout the trial. Change in the proptosis was significant, around 3 millimeter difference. So patients on tepro had a median improvement in their proptosis by 3.3 millimeter, while patients on placebo is only 0.5 millimeter. So a difference of around 2.8 millimeter between the two. You can see the starting proptosis scale, 23, basically both of them around 23, in the placebo only 0.5 millimeter, and the tepro 2.8 millimeter. So patients with a great, and then there was another phenomenon that was observed, that patients with a greater proptosis at baseline had better or larger proptosis response at 24 weeks. You can see here, they divide the group in those who had lower proptosis. So this is the scale of proptosis using Hertel thermometer. So those with 23 or less had a median reduction of around 2.9. Those with 23 and above had a median reduction of 3.7, so significant difference between the two. This is individual patients, and you can see the placebo they were all over the place, but most of them actually did not improve or even got worse. For patients with Tibro, you can see that they have consistently, all of them decreased their proptosis. These are some pictures, baseline versus week 24, placebo worse, Tibro improved, significant improvement, and Tibro here again, you can see the squint and the misalignment improved significantly. This was also shown on the MRI. You can see a lot of inflammation pre-treatment, and post-treatment, you can only see the muscles, the inflammation, the inflammatory response is gone. Quality of life improved. 59% of Tibro patients had few or no signs or symptoms of inflammation. And you can see here the responding rate basically was much better with Tibro compared with placebo. This is individual elements of the CAS score. I don't have time to go over them, but you can see clearly that the Tibro was much better than placebo in all these elements here at the bottom bar. Again, quality of life here, you can see improvement 90% in the Tibro versus 6.3 in the placebo, 12.7 difference. Side effects, discontinuation rate was comparable, 89 in the Tibro, 93 in the placebo. The side effects were on the left side here. You can see some side effects that were more common with the Tibro: muscle spasm, nausea, alopecia, diarrhea, fatigue, hyperglycemia. Hearing impairment is a bit concerning, but otherwise none of these were really serious. And most adverse effects were mild or moderate, manageable, and resolved during and after treatment. Now, there are certain precautions that we have to take care of. Infusion reaction occurred in 4%. So the way to treat it is to reduce infusion. And if it is serious, to interrupt it. Hyperglycemia, you have to watch patients for the deterioration in their diabetes or development of hyperglycemia. If patients have inflammatory bowel disease, then this needs close monitoring. And if there is a flare of the disease, you should stop the drug and do not use it. Again, hearing impairment is very important side effects. And now there are some recommendation of doing hearing tests at the beginning and periodically. And if there is hearing impairment, you should stop giving the Tibro. Specific population that you should not use it, obviously pregnancy is very important, or patients with active inflammatory bowel disease. I just want to briefly mention phase 4, the chronic phase that I mentioned earlier. This was released last year. So patients here are different from the OPTIC and OPTIC-X and the phase 2 trial. Those patients had chronic disease or burnt out disease, 2 to 10 years duration. Mean is around 5.3 years. They had low CAS score. They are not active. They have severe disease, but inactive disease. And they were treated in the same way like the acute phase with teprotumumab for 24 weeks, every 3 weeks. And you can see significant reduction in their proptosis by 2.44 millimeter, while the placebo is only around 0.7 millimeter, significant difference. And you can see also the responder rate in patients who received Tibro was 63% versus only 7%. And you can see the graph here showing you the placebo is different from the Tibro, which is quite significant reduction, 2.44 in the chronic phase. And for that reason, FDA changed the label in April 2023, the label of the drug, saying that teprotumumab is indicated for the treatment of thyroid eye disease, regardless of thyroid eye disease activity or duration. This is very important because previously it was dependent on the activity and it was mostly recommended in the acute phase, but now the duration and activity is not relevant. And with that, I will stop here. Thank you very much for your attention.